Have you ever wondered how a simple cold can suddenly turn into a child screaming with a painful ear infection? Or why a so-called lazy eye is actually a brain problem? Well, in this explainer, we're going to visually map out the chain reactions of these common pediatric conditions. We'll give you a clear, exam-ready picture of exactly how they work inside the body.
Okay, so here's our game plan. We're going to start by tracing the pressure buildup in otitis media. Then, we'll decode that brain-eye miscommunication in strabismus. After that, we'll get into the key post-op risks of tonsillitis, and we'll wrap up with some critical nursing alerts that are absolute must-knows.
First up, the ear. We are going to trace the exact physical journey from a common respiratory virus all the way to the sharp, intense pain of a middle ear infection. It's a total domino effect.
So, here's the absolute key to getting otitis media. It is not just some random infection. The entire thing gets kicked off by a physical blockage. Think of it this way. No blockage, no problem. It's this structural failure that turns the middle ear into a perfect breeding ground for bacteria.
This right here lays out the chain reaction perfectly. It all starts with a simple virus causing inflammation. Now you got to remember, in a small child, that eustachian tube, the ear's little drainage pipe, is shorter and flatter. So when it swells up, it gets pinched shut. All of a sudden, the fluid that's supposed to drain out has nowhere to go. It just sits there, becoming a stagnant pond, a perfect home for bacteria. And all that trapped, infected fluid builds up and puts this immense pressure on the eardrum, and that's what causes that sharp, terrible pain. And what's so powerful here is seeing how every single symptom connects right back to that internal pressure cooker. That sharp pain, that's the eardrum being stretched to its limit. The fever, that's the body's alarm system going off because of the infection. And when you see a baby pulling on their ear, they're not just being fussy. They are literally pointing to the source of the pressure. It all leads back to that one blocked tube.
Okay, let's shift our focus to the eyes. We're about to see how it looks like a simple muscle imbalance can actually escalate into a serious neurological issue, one where the brain literally starts to shut down vision. This is strabismus.
At its core, this whole thing starts out as a pretty straightforward mechanical problem. You've got these 6 little muscles around the eye that are supposed to work together to aim both eyes at the same target. But in strabismus, they're out of sync. So one eye looks straight ahead, and the other one, well, it wanders.
So you might be thinking, okay, if it's just a muscle issue, what's the big deal? Why is this a neurological risk and not just a cosmetic thing? And here's why. The brain is getting 2 totally different pictures, one from the straight eye and a different one from the misaligned eye. To avoid the confusion of double vision, the brain makes a pretty drastic choice. It starts to ignore, to suppress the input from the weaker eye. Over time, the neural pathways to that eye just weaken and fade away, leading to permanent vision loss. We call that amblyopia. The eye itself is perfectly healthy, but the brain has basically turned it off. And this is exactly why these assessment clues are so revealing. When you see a child tilting their head, it's not just some cute quirk. You are literally watching their brain try to physically realign the 2 conflicting images it's getting. Squinting or closing one eye? That's an even more direct move. The brain is basically saying, you know what? I'm just going to cut off one of these confusing signals. So the treatment logic is all about retraining the brain. By patching the good eye, we force the brain to pay attention to the weaker one. It's basically physical therapy for the neural pathways. This occlusion therapy makes those dormant connections fire up again, strengthening that brain-eye link and hopefully reversing that slide into permanent vision loss.
Okay, on to our final spot, the throat. We'll talk a little about tonsillitis, but the real, critical focus here is the #1 post-op risk you have to be watching for after a tonsillectomy.
First, let's just get our bearings anatomically. As you can see, the tonsils are positioned strategically right at the entrance to our respiratory and GI tracts. They are the immune system's frontline soldiers, the bouncers at the door, sampling everything that tries to come in. Now, this inflammation is just the body's natural response to fighting an infection. It means the tonsils are doing their job. But when these infections become chronic, or the tonsils get so big they block the airway, they become more of a problem than a solution. And that's when a tonsillectomy becomes necessary.
And this brings us to the most critical point for post-op care. That area where the tonsils were is now an open wound, and it's in one of the most vascular or blood-rich parts of the body. Because of this, your absolute #1 priority has to be monitoring for hemorrhage.
This is the sneakiest but most critical sign of a post-op bleed. You're not always looking for a big, dramatic gush of blood. More often, it's a slow, quiet trickle down the back of the throat.
The child will instinctively swallow that blood, especially if they're sleeping. So if you notice frequent swallowing, that is a massive red flag. That is your high alert signal for a potential hemorrhage.
So every single one of your immediate actions should be about protecting that fragile wound and the airway. You position the child on their side, so any potential bleeding drains out, not down. You actively discourage coughing or clearing the throat, because that can easily pop the delicate clot that's trying to form. And while you'll have suction ready for an emergency, you avoid using it routinely because it can traumatize the site and actually trigger a bleed.
Okay, let's wrap this up with a few rapid-fire, high-yield nursing alerts. These are the kinds of details that show up on exams and make a huge difference in your practice.
Now this isn't random, it's pure anatomy. In a little kid, the ear canal curves downward, so pulling the lobe down and back physically straightens it out. In an older child, the canal curves upward, so you pull the pinna up and back. Remembering this simple rule makes sure the medicine actually gets where it needs to go.
This is a big one, and every choice here is based on risk prevention. We avoid red or brown liquids because if the child throws up, you won't be able to tell if it's juice or blood. We avoid milk products because they coat the throat, which makes the child want to cough or clear their throat, and that can disrupt the surgical site and cause a bleed.
And finally, this is maybe the most important piece of parent education you can give. A kid might feel way better after a few days, but that doesn't mean the bacteria are gone. Stopping the antibiotic early just lets the strongest, most resistant bugs survive and multiply. You have to finish the full course to truly wipe out the infection.
So that leaves us with this final thought: your ability to connect these dots, to see a simple head tilt not as a habit, but as a brain trying to fuse two images, or to recognize frequent swallowing as a sign of a dangerous bleed. This is more than just stuff you need to know for an exam. This is the heart of pediatric nursing. It's how you protect a child's fundamental ability to see, to hear, and to grow up safely.